you. Right. Dimensions of health and illness. Yesterday we talked about primarily the social determinants of health. Some definitions of health, what it is. Discovered that it's not as straightforward as, I don't know, maybe some people thought it was straightforward. But it's definitely a complex area. And there's all sorts of dimensions of health and of illness. So we're exploring some of those today, and we'll be introducing you to ideas about health beliefs specifically. And then we'll be unpacking them in the tutes for half of you this afternoon and for the other half of you tomorrow. Okay. So, think of an iceberg. What do we know about an iceberg? What's the most cliched fact about an iceberg? That 90% of it is underwater. And the same with health. 90% of me is underwater. What do I mean by that? I mean that I have a life. This applies to you as well. I understand some of my life. Some of that understanding I can put into words. And some of those understandings that I can put into words, I choose to put into words with other people. We're all like that. Who thinks they're not like that? Anybody? Can you see how you are like that? I'll repeat it. We all have a life, 100% of our lives, in totality. Some portion of that, not the totality, we understand. Some portion of what we understand, we can actually explain to ourselves. And some portion of what we can explain to ourselves is public. We choose to share with others. Our health is like that. State of health is what you can see. What you can see above the water. Our lifestyles and behaviours, you might have aspects of your lifestyle that not many people know about. Maybe you're an open book. Maybe you have secrets. Who has secrets? Come on, every hand should be up. And that doesn't change. You have habitual thoughts and emotions and beliefs. Emphasis on this word, habitual. You to an extent, they're not controllable. They're just automatic. I say, spider. Some of you look up. Say fire in a crowded theatre. Emotions are more powerful than thoughts. Beliefs are emotional, they're not rational. That doesn't mean they're not valid. Going deeper, your sense of misspelling, spirituality, being, meaning is probably the most useful word there. What is it that gives your life meaning? What is it outside of yourself? For some people, it's Collingwood. And that's okay, I suppose. But the research has consistently shown that people that have something that gives their life meaning outside of their own bodies do better than people who don't, from a health sense, in all sorts of ways. Their longevity is better, their mental health is better, their general state of health is superior to people who don't have a sense of meaning. And there's even been research that seems to suggest that it is actually true that you can die from a broken heart. It can actually kill you. Then right at the base, right in the depths, we have what is our source of well-being? What is our life force? What is our, if you like, we want to go even deeper than this. What is our purpose? What are we here for? What's it all about? Would some people say it's still a spiritual thing? Other people put a religious frame around that. Some people call it something else entirely. So I'm going to do that. People stuck in traffic and still getting. So to understand illness and health, you've got to look below the surface of what you are seeing TPR-BP. You've got to look at a person's lifestyle and behaviour, what drives them unconsciously or subconsciously, what's important to them. Okay? There's a little acronym that's often a good little tip for a discussion starter, way to guide some small talk, called FORM. Who's heard of FORM? Family, occupation, recreation, meaning. If you can't think of something to say to a person, think, have I asked about their family? Have I asked about their work? Have I asked about what they do for fun? Have I asked about what's important to them? Everybody's got something to say about those four things, and most people will have something that they're willing to share with you. Tips for placement. Okay. Once again, we looked at this yesterday. The 8 prerequisites for health. And most dimensions of health and illness fit into one of these 8 areas. In fact, I think it's hard to think of one that doesn't. Peace, shelter, education, food, income, stability in the ecosystem, enough resources. So I didn't do it. And a socially just and equitable system that we live in. I promised we'd go to Maslow. The thing I want you to know, who's seen Maslow before? Okay, forget everything you know. Because what people don't talk about with Maslow is this word here. The important thing to know about Maslow is that it is about motivation. Your motivation for your physiological needs are fundamental. Try not to breathe. I learned scuba diving once and trained myself not to breathe for 3 minutes underwater. I don't think I could do it. But those needs, those urges are very difficult, if not impossible, to control. Once those needs are satisfactorily met, you are motivated to seek safety. You are not motivated to self-actualize if you don't feel safe. Can you see how this works? These are not all at the same level. Not everybody is able to aspire to self-actualization. It's a matter of what people are motivated to. And if somebody is struggling with their sense of safety or their sense of belonging or their self-esteem, then it's nonsense to say, let's have a peak experience now. And Maslow has been criticised over the journey by people saying that you can't be in a self-actualised state all the time. Of course you can't. But the people who criticise him miss that word motivates. You've got to satisfy the lower needs before you're motivated to go higher. You've got to have breakfast before you take notes in a lecture. One is a higher order skill than the other. Sorry, that's okay. I'm just cutting the noise down a bit. Notice also that once something is taken care of, you take it for granted. Who thinks about their breathing? Who thinks about being thirsty, except when you are really, really thirsty? A few years ago, there was a debate in Australia about whether we need a Bill of Rights. And the observation was made at a forum I was at that the motivation for a Bill of Rights is higher when society is unstable and people feel unsafe. The American Declaration of Independence was written in the middle of a war. Have you read the Australian Constitution? It'd put you to sleep because it was written by bureaucrats. What I'm describing to you is what's called Herzberg's motivation hygiene theory. And the idea about hygiene in relation to health goes back a long way, back into the 1800s. Talking about sleep hygiene, all sorts of hygiene, and not hygiene in the sense of cleanliness, the way we think about hygiene, but hygiene in the sense of health. So a healthy pattern of behaviour, a healthy pattern of, in relation to sleep, rest, sleep and activity would seem to be a hygienic. Okay, that's enough of Maslow. This is one you may have seen. Who's familiar with the food pyramid? Forget the food pyramid. It's been superseded. This is the new one. It's the food peace symbol. I think it looks like it anyway. Maybe I'm showing my age. They've got now equal portions of grains and vegetables. In the news this week, they're actually recommending something that's been around the traps for a while now, that people should eat not 5 serves of fruit and veg, but 10. I'm thinking, I need more supplements, as long as they're plant-based and organically grown. Also, roughly equal portions of fruit, proteins, and dairy. I don't know whether dairy is still cheating a little because technically it's a protein product. But it's probably, I don't know. I think it's an improvement on what has gone before. One of the criticisms of these healthy eating guides has been the undue impact and influence from the industry. If you look at controversies that arise over and over about healthy stars and getting the Health Foundation tick. Yeah, there's people with vested interests in health that are not necessarily got health as their primary motivator. Let's just say that. I'm sure you know what I'm talking about. None of today really should be anything you don't already know. You know that a variety in your diet is good. Your parents have been telling you that for years. Maybe you're just now starting to believe them, or you've worked it out for yourselves. And you can't understand why your parents still buy your little brother McDonald's. You know, don't they know how bad it is for you? Something simple. Balance, all things in moderation, having a plan. Okay, yesterday we talked about determinants of health. And one of the things that can get in the way is being time poor, as well as being economically poor. Who knows people who are time poor? Yeah, from work? Yeah. You go home and you think, oh my God, what am I going to cook for dinner tonight? Haven't thought about it. And what's the easiest thing to do? Get some takeaway on the way home. Is that the healthiest choice? Probably not. Yeah? Is that something that resonates with people, or with people that you've seen? You don't need to tell secrets here. You can talk about other people. Okay. This is a nice general rule, but as I say, it's not always manageable. Oh, for heaven's sake. Excuse me. That was my daughter. Who's your age and should know better. Where's Russell? Okay. Why have I brought up omega-3? I mentioned supplements earlier. There was a Four Corners program on nutritional supplements. They always seem to roll out that topic when it's a slow news week. There's not much else to talk about. But omega-3s, as long as they're properly produced, as long as they're not rancid, do have some reasonable evidence as antioxidants. Some people overblow the claims about all sorts of things that we won't go into now. But as antioxidants, one of the good things about omega-3s is it's very difficult to have too many of them. The ALAs that are plant-derived, and the EPAs and DHAs that are marine-derived. And lots of arguments about which is the best source. The point is, if you know anything about your omegas, the ratio of omega-3 to omega-6 or other omegas is supposed to be roughly 1 to 6. Most people, it's 1 to 15 or more. We eat far too many breads and grains in Western society, and not nearly enough fish or ALA-containing products, or your polyunsaturated fatty acids. Fat's had a bad name over the years. But not all fat is bad. Don't leave that. Little pieces about the ALA content of plants. Alpha-linoleic acid is a type of polyunsaturated acid. So it doesn't solidify when it's with temperature changes. Okay. That's why it's so good as an antioxidant, because it sort of just keeps staying structured. Okay, so some flax seeds have had a lot of press. Walnuts less so. Maybe people don't like the taste. But nuts, green vegetables, generally pretty good. Different sorts of fish. Generally, they're found. Farmed fish don't do as well as wild caught. Why? Because farmed fish are fed pellets that are basically bread-based, so their omega-3 content is lower relative to their omega-6 content. Roughly 650 milligrams a day, or 3% of total calories. I take 3 a day. I know people that take 9. Sounds like a lot. But the guy that I know took 9 had massive cholesterol and reduced it with that many omegas over the journey. Oh, there you go. There's the ratios. Currently from about 14 to 20 to 1 in the recommended ratio. It should be ration. As I say, some of these claims are a bit overblown and people get carried away with them. This word here is interesting because nobody really knows what an adequate intake is. Certainly for inflammatory conditions, and again, what is an inflammatory condition? There's a whole field of exploration looking at the role of inflammation in all sorts of different conditions. Bone health. Who's concerned about bone health? One of the things about a lot of conditions is that they are slow burners. The groundwork for osteoporosis is laid down in your teens. If you were not exercising sufficiently as a teenager, then in your 60s and 70s, you will be at risk. Unless you do some quick catch up in the meantime. Same with a lot of things. My dad died of complications from melanoma. And the root of the melanoma was when he was in his 20s gardening. Because in those days, slip, slop, slap was not heard of. People didn't do it. And 40 years later, that catches up with you. But we don't think that sort of long term, do we? So your peak bone mass is achieved during adolescence. Another one's spelled wrong. I've got to go through this. Through proper diet and physical activity. You notice they've recently, well actually probably a long time ago as far as you're concerned, recently for me, increased the recommended daily intake for vitamin D. The recommended daily intake, or RDI, for whatever nutrient you care to think about, were first devised during the Second World War, when they worked out how much it was necessary to give a prisoner of war for them to avoid starvation. So your RDIs, that mostly haven't changed very much since then, are not a terribly good measure of health. if you're meeting your RDIs, you might be avoiding starvation, but it doesn't mean you're going to be healthy. Now, vitamin D is a bit of an exception to that. A few years ago, they massively increased the recommended daily intake of vitamin D to the point that most people can't get it from sunlight alone. Or if you were, you'd be so covered in sunscreen that you'd just be sliding off the bean chair. Or you'd be putting yourself at massive risk from skin cancer. And I mean, you can make a case for a lot of health issues that there's a balancing act. Which do you want to be more at risk from? Vitamin D deficiency, rickets, or skin cancer? You can't have it both ways. If one goes up, the other one's going to go down. So the recommended calcium intake, which goes with vitamin D currently, is about 1,000 milligrams a day. It used to be 400, I think. Most people are under, whereas under the old ranges, most people are over. Now, there is some argument going around that the recommended intake change is at least partially due to industry pressure as well. Drink more dairy, get more calcium, sell more milk. There are reasons for why we don't have as much calcium in our diet these days. Soft drinks, which contain phosphorus and caffeine, inhibit calcium absorption. Obviously, coffee. Too much alcohol, an acidic diet. There's all sorts of debate about what an acidic diet means. General consensus is that your diet should be alkaline, but I'm not going to go there because it's quite a complex area in itself. Smoking has all sorts of unexpected effects, and too many carrots. I think excessive vitamin A can have an inhibitory effect on calcium absorption as well. Phytonutrients. Who's heard of phytonutrients? You will have. You will have heard of some. We have macronutrients, which are your carbohydrates, proteins, and so on. You have your micronutrients, which are your vitamins and minerals. And then you have your phytonutrients. And until really quite recently, we didn't know what they did. But we've now realized that they're part of a vegetable's immune system. They're very good antioxidants. You can't get them readily from factory-produced supplements, which most supplements are. You have to get them from your diet or from an organically produced source. You would have heard of carotenoids. It's a thing that gives carrots its colour. And we thought that's all it did. We thought it was just a food dye. But it's an example of these phytonutrients that are an example of the plant's immune system. Flavonoids you might have heard of. Isoflavones in relation to soybeans. Lutein from leafy green vegetables. Is actually given as a supplement in isolation. It's meant to be good for macular degeneration, sort of eyesight problems. They're the ones we know about, or some of the ones we know about. There's an awful lot of them. Lycopene in tomatoes. We know that tomatoes are a good antioxidant. Lycopene is why. Dietary fibre. You have too much protein in your diet, or you get constipated for some reason, or somebody says, oh, you need some fibre. Have an apple. Fibre is the structural carbohydrate of plants. There's two types: insoluble, that goes straight through you, and soluble, which is the good stuff. You want to blend. You want insoluble and soluble fibre in your diet wherever possible. The insoluble fibres are primarily from grains. Solubles are mostly from green vegetables. Also important to have enough water. How much water? Rule of thumb? How do you work it out? 8 litres. You say 8 litres. Have 8 litres, you're walking around with a leg bag on. Okay. Somebody like me, probably 3 litres. Somebody like you, probably 2. What's the difference? They reckon about 30 milligrams per kilo of body weight. Millilitres, rather. 30 millilitres per kilo of body weight. So there's a sum for you. You need to get good at these sort of sums because you'll be doing medicine calculations in second year, and you will hate them. Trust me. But work out for yourself roughly what is your weight. Multiply that number by 30. That's how many millilitres you want. How many millilitres in a litre? 1,000. Okay, so that'll give you your figure of how much water, not coffee or tea or soft drink, how much water you should be having every day. More or less when it's hot? More, because you sweat it out. Okay. Probiotics. Live microorganisms. Not essential, but they've been found to be beneficial in your diet to promote a healthy digestive system. You've heard of Yakult. Probably shouldn't be advertising specific brands, or what the heck. Yogurt, not sure what kefir is. Cultured milk products. Sauerkraut, apparently. Tempeh and miso. Japanese soup, meant to be good in probiotics. There's some evidence to suggest that probiotics can help prevent colon cancer, reduce LDL, which is the bad cholesterol, and reduce blood pressure. Has a positive effect on your immune function. You think about vaccinations or immunizations, how they work. Anything you do to stimulate your immune system, it feels a little counterintuitive. Who's seen there's Facebook posts going around about one of the best ways to help your child's immune system is going to let them play in the dirt. You seen those? Yeah. Because they get used to the bugs that are out there. And one of the risks of trying to be too clean all the time is that you don't build up a resistance to what's around. And it's one of the reasons why, for example, when people go to a new country, even visiting, you go to Bali and you come back with indigestion. Who's done that? Yeah. Well, if you haven't, you probably will, some of you at least, at some stage. Because you're not used to the system. Whereas the people who live there drink the water all the time, no problem. Same with India. You hear all sorts of Joel, the cricketer the other week who had to sort of leave the field suddenly. He just had to go. Didn't happen to the home side. Hmm? Yeah, Renshaw, that's it. Yeah. Yeah, okay. Some potential benefits, found a nice picture. Shorten the duration of infections intestinally. Can manage lactose intolerance, interestingly enough. Reducing infections in the urinary tract. Irritable bowel syndrome can be managed, and also diarrhea. So a lot of benefits in a gastrointestinal sense, specifically attributed to probiotics. The thing about nutrition is that the evidence is mixed in a lot of cases. It's very difficult to be definitive about any of these. Nutrition by itself is not a magic cure for everything, but it's part of the mix. Okay, there are non-digestible carbohydrates that stimulate growth of beneficial ones, evidently. There are some naturally occurring probiotics in plants and also in some other sources. Weight management. Who thinks it's important to manage their weight? Who thinks the BMI is a reliable indicator of whether you're overweight or not? Okay, why not?
Let's use a weightlifter, for example. They can come in under obese because they've got a much denser body weight with the muscle itself.
Yeah, their proportion of muscle to
so much heavier.
Yep. What else do you notice that is not on there? That chart measures your height along the horizontal axis and your weight along the vertical axis, and then plots and has these ranges of obese, overweight, normal, and underweight. And numbers. So if you're over 30, you're obese. If you're over 40, you're what's called morbidly obese, I think, or it might even be 35. And under 18.5 is underweight. And if you're 160 centimeters and you weigh 72 or less, then you're seriously underweight. Now, some people with an eating disorder, that can be a real problem. I've seen people down here who are about that tall and a BMI of low 30s in some cases. Now, there's no doubt that there are severe risk implications for people's health at that end of the scale. Similarly, up here, there are major health problems. One of the reasons that the BMI is being rethought a bit is that it's not age sensitive. They're actually finding in recent years that a little bit of padding is protective as you age. They're finding skinny people, skinny elderly people break their hips more readily, for example. Maybe don't bounce as much. I don't know what it is. But this may be valid up to about 35 or so. After that, some of these numbers need to be taken with a little bit of not a grain of salt, but as part of the overall mix. Once your metabolism slows, and it will. Who's over 20? Your elastin is gone. You are starting to sag. You are starting to get wrinkles, and they will not go away. Aging happens, and we can age well. There's a great book years ago called Aging Well. And there's lots of data about what aging well means. But we don't stay the same. We don't have our 20-year-old body when we're 50. It's inside us somewhere. Okay, one of the things I always like to say is that Shrek is right. We are like onions. Okay? Our 20-year-old self will always be inside us, but you can't always see it. Okay. Bit of an infographic from the Victorian Department of Health. Probably more useful for you to sort of have a look at it or at your leisure, or even download it from Drug Info, the ADF website, Australian Drug Foundation, Alcohol and Drug Foundation. We know a lot about alcohol and other drugs. So you've got to ask the question, if we know so much, why is it such a problem? Because knowing something doesn't change behaviour necessarily. Behaviour, what did I say with the iceberg? Is it rational or not? It's not rational. There's a reading on Brightspace called Change or Die that talks about that. If you're told to make a lifestyle change that will save your life, do you think you would make it? No, you wouldn't. Most of you would not make it. If you had to make a lifestyle change to stay alive, most of you would not make the change. Read the article. Change or Die. It's on Brightspace. Who knows what a standard drink is? Your average restaurant serving of white wine is 1.4 glasses. So you have 2 of those, you've had 3 glasses, just about. Same as sparkling, slightly more with red. Even a can of beer is 1.4. So when you're counting, and what's the counting? How many drinks to stay under 0.05? 5 drinks in the first hour will get you to 0.05. Hang on. 5 drinks in the first hour will get you to 0.05, and a drink every hour for the hour following that will keep you there. That's if you're male. If you're female, yeah, it's a lot lower. Often 2 will get you there. The recommended maximum daily intake of alcohol is 2 drinks a day. So maybe that's what you're thinking of. The NHMRC has safe drinking guidelines, which is where these come from. But what people don't realise is what constitutes a standard drink is often not what they think it is. Okay, smoking. I'm sure you've seen some of these. Again, read Change or Die. Because smokers know this stuff and they do it anyway. Why? Because behaviour is not rational. Behaviour is emotionally driven. I don't need to go into those cancers and chronic diseases. And yes, there's always somebody that seems to be the exception that lives till 90. We're not all Keith Richards. What I don't understand is if this is in your cigarette, the number of these you see lying around on the footpath, left there by otherwise civilised people, when there's perfectly good ashtrays. I mean, these are some nasty. Substances in some of these things. I mean, this is what it is. This is other places you find it. You also see formaldehyde in food preservatives, just by the way, but anyway. You've seen those pictures of a cheeseburger that's been sort of lying out for weeks and it hasn't changed? That's formaldehyde doing that. All right, immunisation. Everybody's got an opinion on immunisation. A few things to keep in mind. Just a sort of bit of a primer. John will go into the immune system with you properly. Has he started building your body yet? He will. The immune system fights infection and keeps a record of every microbe that it has encountered and overcome. We are very well designed in the sense of keeping out the big stuff. Okay, especially our skin, lungs, and digestive tract, and I would add your brain. Okay, the way the body keeps things out that shouldn't get in is really quite amazing. There has been concern about vaccine safety, and frankly, as I say, decision making is not rational. But when something comes along that we don't understand and there are divergent points of view, then people get confused. This happens. That's why some people vote one way and some people vote the other way based on the same data. Most reactions from immunisations are generally mild and resolve by themselves without needing medical treatment. Now, there's going to be extreme cases that are exceptions to that. But the last point is the major one, that the risk of complications from childhood diseases is much higher in a societal sense than the risk from immunisation. So, for example, we are now having something that was unheard of 20 years ago, a measles epidemic, because in some areas, people are not getting vaccinated. Immunised. Another piece from the health department, basically following through, and we now have the rule about no jab, no play, about childcare centres and so forth. That's been brought into legislation. So this is the schedule from birth all the way through, and I think up to here it's compulsory, up to here it's sort of recommended. Yeah.
The mothers that choose not to get their children vaccinated.
Mm-hmm.
What is the ratio or the statistic of their children actually living a good and healthy life, even though these diseases?
Well, think about it. How long has this been going on? How long have anti-vaxxers been around?
Well, I think
10, 20 years. Not long enough to get longitudinal data. So we haven't seen those kids grow up and grow old, so we can do the comparative studies. It's all speculative at this stage.
Yeah, so if it's only like 20 to 30 years ago, so the people before that who are living now would have lived through those diseases. Is that right, or did they?
But people didn't. People died of measles, and people are dying of measles again. Whereas there was a period where people didn't because people got immunised. Yeah. You know, some of your parents may remember polio. I want people living in iron lungs. Franklin Roosevelt, an example, paralysed by polio. You know, there's these massive diseases that you still see in some parts of the world. Diphtheria, no one. Tetanus. These used to be things that people died of. One of the reasons people were so scared of Zika virus last year and the effects on microencephaly is, yes, it's a terrible disease, but the issue is you don't see it that often. All right? You're seeing somebody with spina bifida. Now, I'm not saying that's something you can prevent with an immunisation, but you know how you can prevent spina bifida? Iron deficiencies. Folic acid prevents spina bifida. Now, it's no good blaming people for things that happen, but if you know that something could happen and the risk of that happening is greater than the risk of something else that might happen if you take a safeguard, you know, people in the US pleaded the Second Amendment, I think, when they were told to wear seatbelts. Because, you know, it's my right to wear a seatbelt or not. I don't like the feel of it on my around my neck. I mean, grow up. Those sort of situations. And yeah, people get confused by all the information that is out there. Particularly these days, people can put up stuff on the internet, and once it's up there, it stays up there. Doesn't matter whether it's true or not. You know, the person themselves has to decide to take it down. And if they don't take it down, it's there forever. There was a case a couple of years ago where a hospital decided to replace doctors with parents who have done their research. This could be a true story. It's not, just in case you're wondering. Yeah. I mean, there are people around who would read that and think, oh, that's a good idea. Because I don't trust the doctor anyway. You've got to get good. When you talk to Bob in second year, you've got to get good at assessing your evidence. Is it good evidence? Is it reliable? Is it reputable? Is it accurate? All of that. So, talking again about illness and disease. Going back a little bit to what we talked about yesterday. An acute illness or disease, it's not that it's small and good looking, it's acute. It's rapid onset, short duration, subsides quickly. And chronic is not a form of marijuana. Well, it is. But it's an illness or disease that has a duration of at least 6 months. Typically slow onset, may or may not have periods of remission and exacerbation. Sometimes people have a chronic course that is pretty constant. We talked about morbidity and mortality yesterday. When people become ill, they behave in different ways. These are called illness behaviours, the way you behave when you're ill. Sounds fairly obvious. These are ways that people cope. I'm sure you can all think of those. You stay in bed. You don't eat as much. What else do you do? Yeah? What else do you do to cope? You scratch your head. Yeah? Yeah? Maybe you dress up warm. You're feeling like you've got to chill. Yeah? So what have you thought about it? You think of range of ways that you cope when you're feeling ill. They're highly individualised according to how old you are, your gender, how well educated you are, what you do. If you're a construction worker and your back's gone out, you probably take the day off. If you're a teacher, then maybe you still go to work and you just take an osteo. Or keep your Voltaren up, in my case. It's affected by socioeconomic status. What are you noticing about these? They're similar to the determinants of health that we talked about yesterday. So your illness behaviours are affected by what is determining your health in the first place. Personality we might get to at some point, but that's majorly complex. We talk about that in the second year a bit, but it's huge. Stages of illness, there are 5 of them. You experience symptoms. At that stage, you may talk to somebody else, somebody significant in your life, clarify what's going on, have a glass of water, have a coffee, whatever you do that you think might help. Second stage is you take on a sick role. You say, okay, I'm taking the day off, really don't want to, boo-hoo, but I have to take a sickie today. What a shame the cricket's on. You engage in self-treatment. You're excused from your normal duties. Third stage, you contact the doctors or you get some sort of medical care. And validation of what's happening for you, validation of your behaviours, getting your symptoms explained can be a relief to a lot of people to get a diagnosis, which is a medical thing, not something we necessarily need to worry about as nurses. You may get some disagreement from others about that, but as a psych nurse, my view is it is not our job to diagnose. Diagnoses are how doctors get paid. It is our role to engage with patients and work with them where they are. A lot of people go to medical care for reassurance or to get some sense of what's going to happen next. And they accept or deny the advice that they're given. Fourth stage, you're already in a sick role. Sometimes you get people go into a dependent client role. That's particular in relation to delays in treatment, when treatment doesn't seem to be working very well, and you move from dependence to independence as time goes by, hopefully. Can get complicated to fulfill your role obligations if you're in a dependent client role, because they can conflict. And then recovery. You're returning to your former lifestyle. Sometimes there's major adjustments in functioning that's required or mandated because of things that have changed. You've lost a limb. I don't know. Okay, so they're your 5 stages of disease behaviours. Here are some of the impacts that an illness can have on a client. There can be financial challenges. Adjustments needed to role, as we mentioned. Changes in body image, loss of autonomy, changes in diet. People lose a lot of weight and then, hey presto, when they get well again, put it all back on. Maybe you don't sleep very well either. When you're having a chronic course, there we go. We've got a bit to go here. It's more complex. Chronic diseases will account for nearly half of all deaths and 80% of disability by 2020. We saw that yesterday. That's a lot. And the healthcare services are pretty much overwhelmed with dealing with chronic illnesses. Most of your nursing will be to do with chronic illnesses. It used to be called the revolving door syndrome, as if it shouldn't be happening. It's happening. We try to reduce it, but it's not going away. Major funding pressures. The ageing of the population is a major contributor. It's interesting, a lot of these conditions, there was some data from Queensland in emergency departments. I think it was around Toowoomba. Specifically, they were saying that a lot of these conditions are now being seen at emergency departments, and they're actually not appropriate admissions to emergency departments. You know, people going to an emergency department with a chronic condition, okay, you don't do that. Some people, you know, simply use the ED as their GP. Maybe it's easier to get in, I don't know. Or maybe it's just about the bulk billing. People with chronic diseases are more likely not to participate in the labour force, are less likely to be employed full time, and more likely to be unemployed. Remember what I said yesterday about correlations? These are not causal links necessarily, but they are strongly correlated. Need to mention Aboriginals and Aboriginals and Torres Strait Islanders. Where is that? Yeah. Remember what I said about tolerance and going to Bali earlier on? Part of the issue is that in an evolutionary sense, Aboriginal populations are not used to a Western lifestyle, and you know, a lot of the issues around, say, processed sugar that Anglo-Saxons and others, it's less of an issue for. Big issue if you're not used to it. And it's only a couple of 100 years. Yeah. Top 10 leading causes of death. Not a lot different, but the rates is what we need to be concerned about. You know, the Closing the Gap initiative is struggling, and will, I think, continue to struggle for some time. Okay, so in summary, characteristics of chronic illness, it's more than just about treating the medical problem. It might be about treating a person's, or paying attention to a person's body image, self-image, self-esteem, sense of safety. Go back to Maslow. Chronic illness can be about all of those things. I know how old is she? 20-year-old who's just got her own oxygen cylinder that she carries around with her permanently, but she needs it. Her asthma is that bad. Common misconceptions about chronic disease. Number one, everybody has to die from something. You can die and be perfectly healthy. People do. You don't have to die from a chronic disease. There's a bit of fatalism involved in that. People can, but there may be the exceptions that prove the rule. Live to an old age, even if they live unhealthy lives. The question of blame is a bit of a furphy. It's not really relevant to blame somebody for being sick. Need to move on a little bit because the time's on the wane. Heart disease is the biggest killer of women. Not everybody is aware of that. Women are 4 times more likely to die of ischemic heart disease than of breast cancer, particularly these days when breast cancer is so treatable. This is, again, an American image. But we're pretty much a state, or at least a dependency. Bone and joint health problems are among the most prevalent and debilitating health challenges that anyone can face. Lots of work absences, lots of visits to the doctor, lots of surgery. I mean, they're massive increases that they're talking about here. Disability claims, workplace injuries. Who's got arthritis? Okay. The rest of you, most of you will at some point. It's not pleasant. Sorry to burst your bubble. Okay. From a healthcare system point of view, we have 5 identified deficiencies. Fragmented care. Remember the ambulances at the bottom of cliffs? The patient's role in management. I think we're improving on that. Sporadic follow-up. Ignoring the impact of community services and peripheral services, services that aren't seen as necessarily to do with health. And prevention is underused. It shouldn't surprise you to hear me saying that by now. Costs, that's a big number, 35 trillion to treat heart disease and cancer over 25 years. That's a lot of money. Newly diagnosed cancer cases, 300 billion. COAD, 400 billion. We do in Australia, I think, sometimes better than in other places. Some of the initiatives that are helping: better access to care and medicines, although that's patchy. If you look at things like EpiPens, and the fact that diabetes test strips are now no longer claimable, for example, just for two. Making sure that what we're doing in the healthcare system is best practice, looking out for risk factors and preventing those, researching new approaches, supporting people. Again, you read that article, Change or Die. Support is very important. And better management and self-management, more consistency through better record keeping. Just briefly mention the role of primary healthcare. We talked about this in week 10 in a bit more detail. But primary healthcare, mainly based in GPs, is important to provide continuity of care and all of those other things, care coordination, better outcomes, and effective management in the community rather than being a burden on the healthcare system. Certainly the tertiary system. Okay, there's a little activity here. We've maybe got a little bit of time for it. Just have a quick read through those. So maybe this side of the room, look at John. Just move John. Back side of the room, look at Sam. So John and Sam. They've both recently had a heart attack. They're both aged 47. Okay, this side of the room. Why does John consider himself healthy? No, this side of the room. Okay. Well, why does Sam feel unhealthy? Okay. He's not back at work. Yeah, so he's not back into his functional normality. Yep.
It probably just goes down.
Yep.
He's also got expectations, so it's probably not living up to his expectations.
Okay. Okay. I mean, there's factors in Sam's situation that are not in John's, aren't there? Yeah. Yeah. They're both exercising.
Sam often talks about being feeling as we have a positive feeling.
Mm-hmm. Yeah. Yeah. Yeah.
Just basically about the positive.
Attitude doesn't hurt. It's about what are the risk factors? What are the factors that are making things potentially worse? And what are the protective factors? When we get to health promotion in a few weeks, we'll be talking a lot about risk factors and protective factors. And a protective factor is something that increases the likelihood of things improving from where they are. Okay. There is an illness-wellness continuum that's sometimes spoken about. All you need to be in is here. don't need to aspire to here. This is sort of the high level stuff. But treatment is designed to get you to here. It's really up to you how far up here you want to go. Not many people want to go down in this direction. Some of the things that influence health practices is how we understand health and well-being, how well nurses understand what's going on for the clients, what the client themselves believe about health, which we'll talk about in a second. And perceptions of wellness. So we have clinical models. These are again echoing what we talked about yesterday. Role performance models, adaptive models, eudaimonistic something, which is basically equilibrium. And the model of understanding or the model of belief that you're applying helps to explain for you the relationship between health and well-being and illness or injury that you undergo. Okay, so you can be injured but not feel sick. Or you can be minorly injured and feel a lot sicker than somebody that's got a major problem. Clinical model pretty much is limiting to the physiological symptoms that are going on. We're looking at the absence of signs or symptoms as a treatment according to the medical model of care. And the goal is to not be sick. The role performance model, okay, I'm okay as long as I can keep going to work, or as long as I can keep fulfilling my role. The adaptive model, health is a creative process. Disease is an obstacle to health. Sometimes a useful analogy to use. What's getting in the way of you being as healthy as you want to be? That word again. A comprehensive view of health that is seen as actualizing a person's potential for fulfillment and complete development. The 4+ model, 4 domains of the self: physical, emotional, spiritual, and intellectual. 4 elements of outer systems, in those senses. And this has been used to assess a person's strengths, what's happening in their environment around them. Remember the socio and ecological view of health that we talked about yesterday early on. That's an example of that. So the interactions between the self and outer systems. And health belief models. Some of you will have heard of a locus of control. Are you in control of your own destiny, or are you subject to fate and you don't have any control over it at all? How likely is a person to participate in disease prevention or health promotion? Like I said, it's not just about having knowledge. Motivation is important as well. People who believe that they have a major influence on their own health, so they can do something about it, they're called having an internal model of health belief or an internal locus of control. They're more likely to make their own decisions. Okay, influenced by individual factors, also modified by a few different things. Health beliefs model, more specifically, what is the health problem? What are the perceived benefits of doing something about it? What are the barriers to action, and how self-efficacious do I feel? How equipped, how capable do I feel of doing something about this? And then there needs to be a cue to action or a stimulus. That's it in a nutshell, and you'll see a picture like that in your book. So what is the perceived threat of the disease? How susceptible do I feel about it? There are modifying factors to that. And also, what is the benefit of taking action? How severe is the disease? Are there any cues to action coming into play? We'll talk about that in the tube this afternoon. But this is very relevant to your assignment. I hope some of you are noticing. So to assess health needs, we're nearly done, I think. Yeah, we are. We're very nearly done. We need to examine the indicators of a person's health, understand their beliefs about health, link a person's information with known health risks for their population group, and assess the community that they're a part of in terms of the resources and barriers to health. Now, as I said to those of you who are here nice and early, on Brightspace, there is a reading guide that includes a link, same link to the health belief model online reading. Those chapters of McMurray and Clendon are worth having a look at, and Talbot and Verenda, which is available as an ebook. Next week, we'll be looking at wellness and resilience in a little bit more detail. So what is health? How does that play out? And Deb Kigali will be coming to give you a lecture on an introduction to health assessment. I'll be giving the Tuesday lecture next week, the Wednesday lecture, and for the following weeks after that, Deb and a few different people will be sort of leading you through the communication aspects of the lecture materials, but I'll still be doing the tubes. Yes. The objectives are as per the subject guide, as an overall piece.
So there's not one for each week. Normally it goes by like they have the objectives for the week.
Yeah, they're not explicitly stated, but basically the title of the lecture, the title of the PowerPoint is the topic of the lecture, and there's more specific objectives for the tutorials, but we'll go through those. Yeah.
Yeah, that's what we'll do.
Not for the lectures so much,
No,
but
for the whole week for this subject.
but for the tubes, yeah. If you go through the subject guide.
Yeah, I went through them, but I wasn't sure if I was like there in the subject guide. They're like obviously.
Yeah.
The usual is dot points. They directly correlate to the slides.
Yeah, no, not in the lecture. I haven't included those in the lectures, but they are in the tubes. For each one. Yeah. I find the tubes are much more a useful learning environment than the lectures anyway. Yeah. Hello. Yeah. You ready to rock and roll? I better go.